Hello to all of you. I'm Dr. Shivika Sethi, and today I'm here to discuss the microbiology recall MCQs that were asked in the recently held INI-CET May 2024. So there were 16 questions from microbiology, and before I discuss the questions, let's just brush through the topics that were asked in the exam. So we had from systemic bacteriology, Group B, a question each from Group B Streptococcus, Diphtheria, Tetanus, Mycobacterium, and two questions from sexually transmitted infections. From general microbiology, we had a question from sterilization and disinfection. From mycology, we had a question from Cryptococcus. From virology, we had a question on genetic material. In the November 2023 exam also, the genetic material was very important. That time, two questions were asked. Then we had a repeat MCQ from herpes simplex infection and a question from parvovirus. From parasitology, we had causes of diarrhea in HIV. Then we had a question on parthenogenic parasite, and we had a question from two questions from Plasmodium. Lastly, from immunology, we had a question on immunodeficiency disorders. So the questions, the difficulty level, I would say, was just mild to moderate. None of the questions were difficult. You could have easily answered the question had you done your microbiology videos or notes properly. So let's start the discussion. Which of the following is the most common disease associated with Streptococcus A galactiae? Neonatal sepsis, pharyngitis with or without tonsillitis, dental caries, and endocarditis. That's a very, very easy question. Streptococcus A galactiae, or the group B beta hemolytic streptococcus, is one of the most common causes of neonatal sepsis. Okay. So remember Streptococcus A galactiae. This is one of the beta hemolytic streptococci. And we know all the beta hemolytic streptococci were serogrouped by Lancefield, right? So we have the Lancefield serogrouping of the beta hemolytic streptococci on the basis of the group, rather the carbohydrate antigen which is present in the cell wall. And they are classified into several groups, group A to V minus I and J, out of which the most pathogenic is group A. We all know it as Streptococcus pyogenes. And group B is what we have been asked the question about, that is Streptococcus A galactiae. Now, apart from the fact that it is one of the most common causes of neonatal meningitis and neonatal sepsis, Streptococcus A galactiae, you must always remember that this is giving two important biochemicals, that is the CAMP test is positive and the hippurate hydrolysis test is positive. The image shown here is of the CAMP test. You can see that the vertical streak is of Staph aureus and the horizontal streak is of Streptococcus A galactiae. And you are seeing these arrowhead hemolysis and hand zones of beta hemolysis. That is the CAMP test positive, right? Now, another important thing to remember about it is that it is resistant to bacitracin in comparison to Streptococcus A pyogenes, which is sensitive to bacitracin. So if you're asked what are the important tests by which you can differentiate it from Streptococcus pyogenes, that is group A beta hemolytic streptococcus, you know these three biochemicals are important there. Let's move on to the next question. Read the following two statements and answer. Faucial diphtheria can cause death due to myocarditis. And statement 2 is bacteremia is seen in diphtheria. Now, faucial diphtheria or any kind of diphtheria, the myocarditis is one of the most, rather it is the most common complication of diphtheria. And this myocarditis can be severe enough to cause peripheral circulatory failure, and it hence becomes the most common cause of death in diphtheria. Commonest cause of death in diphtheria is myocarditis. Second statement is bacteremia seen in diphtheria. This statement, yes, is true. The second statement is false. Why? Because in diphtheria, there is just a toxemia. It's the diphtheria toxin which is disseminating via the blood and causing the complications like myocarditis. There is no bacteremia. The bacteria itself is multiplying at the site of infection, whatever the type of diphtheria, and it is secreting the diphtheria toxin and cause responsible for both the local effects as well as the systemic effects. Right? So our first statement is correct, but the second statement is incorrect. So our answer to this is option C. Remember, diphtheria toxin, that's the most important virulence factor of Corynebacterium diphtheriae. It's an A B subunit toxin. B subunit binds to the receptors. The A subunit is responsible for its action. It inactivates elongation factor 2. So it acts via elongation factor 2 and thereby it inhibits protein synthesis. So one of the four toxins which acts by inhibiting protein synthesis. Do you remember the other three? Which is the other toxin which acts via elongation factor 2? That is exotoxin A of Pseudomonas aeruginosa. And the other two toxins which inhibit protein synthesis are Shiga toxin and Shiga-like toxin or virocytotoxin that is produced by enterohemorrhagic E. coli. They act via breakage of the 60S ribosomes. Okay. Also remember that diphtheria toxin, it's all cells of the body are susceptible to its action, but it has a special affinity for myocardium, adrenals, and nerve endings, MAN. And myocardium, that's why it causes myocarditis. Next important thing to remember about diphtheria toxin is it is one of the phage-mediated toxins. Phage-mediated toxin. So that's the beta phage, the virus which infects Corynebacterium diphtheriae. So earlier, C. diff did not have the genes for the diphtheria toxin, but the phage genome got integrated with the bacterial genome and gave the bacterium the tox gene, which is the gene for the diphtheria toxin. So what do we call this phenomenon? Lysogenic conversion. Earlier, the bacterium was not producing the diphtheria toxin, but when the phage genome got integrated with the bacterial genome, it gave the property to secrete the diphtheria toxin. Let's move on to the next question. A construction worker presents with lockjaw and muscle rigidity. He has a history of exposure to a rusted iron nail through an existing wound, right? So obviously this is pretty clear. Lockjaw and muscle rigidity, we are dealing with the patient of tetanus. Which of the following is the mechanism of action of the toxin responsible for this presentation? So what is the toxin name? Tetanospasmin. And how does it act? It acts by inhibition of the inhibitory neurotransmitters GABA and glycine. What is the site of action of tetanospasmin? It has a central action, means at the level of the spinal cord and the brain stem. It is inhibiting the release of the inhibitory neurotransmitters GABA and glycine. How it is doing so is, you can see that's the motor neuron, whose activity is being controlled by the excitatory neuron and the inhibitory neuron. And here is what is the site of action. So what it does is it cleaves or proteolyzes synaptobrevin. This is responsible for the fusion of the vesicles of GABA and glycine with the neuronal membrane. So once this is gone, obviously there is no release of these inhibitory neurotransmitters, and there is uncontrolled stimulation of the motor neurons responsible for the rigidity and the spasticity seen in tetanus. Moving on to our next question. Read the following two statements and answer. So the first statement is an assertion, second statement is a reason. So we had two questions in microbiology which were assertion and reason statements. Assertion is that the mycobacterium is detected in sputum samples after treatment with N-acetyl L-cysteine and NaOH, that is sodium hydroxide. Yes, this statement is absolutely correct. Before we put up the sputum sample for culture of Mycobacterium tuberculosis, we always treat this sputum sample. That treatment process is called as homogenization and decontamination. I'll just go through the steps in the next slide. And the reason that they're saying is that sputum samples are treated by N-acetyl L-cysteine to kill the commensals and sodium hydroxide to liquefy the sputum. This is a wrong statement. Why? because it is the NALC, NAC, which is liquefying the sputum sample, and it is the alkali sodium hydroxide, which is killing the commensals present in that sample, right? So our first statement assertion is correct, but the reason is incorrect. What is the answer? Answer is option C. Okay. As I said earlier, homogenization and decontamination step is carried out before we put up the sputum sample for culture. And that is done by the Petrov's method. And Petrov's method says use 4% of sodium hydroxide. So here what we do is in a clean sterile test tube, we are going to take sputum and we're going to add equal amounts of 4% of sodium hydroxide. The purpose of this sodium hydroxide is kill the commensals that are present in the sample so that MTB can grow uninhibitedly in the culture medium, right? So remove all competition. So what we do is take the test tube, add equal amounts of sputum, add sodium hydroxide, and shake this manually for 15 minutes. Then you centrifuge this test tube for 15 minutes, again at 3000 RPM. Then take out this from the test centrifuge and decant the supernatant in phenol and take the lower 1 ml of the sediment, right? So by centrifugation, we have nicely homogenized the sputum sample, right? So take the lower 1 ml of the sediment, neutralize this alkali. Now all the commensals have been killed. You want the MTB to grow. So neutralize this sodium hydroxide by N by 10 HCl, and now your sample, that sediment, is ready for sputum culture, right? But some people say that using 4% of sodium hydroxide can be, inhibitory to MTB also. It can kill some of the MTB also. So what they say is instead of using 4%, use 2% of sodium hydroxide and use N-acetyl L-cysteine along with it. And that was the question that was asked. So this is going to liquefy the sputum sample. This is going to kill the commensals. Clear? Okay, let's move on. A 24-year-old female comes to the OPD with dysuria. She has non-irritant, profuse white discharge from her vagina. On examination, her labia were inflamed and swollen. The openings of her urethra and Bartholin glands were congested. On collection of her endocervical discharge, intracellular gram-negative diplococci were found, right? So on gram staining, we are seeing intracellular gram-negative cocci. Which of the following is the most likely cause? It should be the etiology of the urethritis, Bartholinitis, as well as cervicitis. So easy. Obviously, the answer is Neisseria gonorrhoeae, right? So we know gram-negative cocci. We either think of Neisseria species or we think of Moraxella species, right? These are the important gram-negative cocci. And how do we remember them? As the mnemonic venom. It's a commensal, but okay, sometimes we are asked Velonella, that is a gram-negative coccus, and of course, N is Neisseria, M is Moraxella, right? So here amongst them, the answer is Neisseria gonorrhoeae, right? So that's the cause of the patient's disease. Let's move on. This is a picture which is showing us the intracellular gram-negative cocci of Neisseria gonorrhoeae. Drug resistance is seen in which of the following sexually transmitted infections? Now, this question you can answer only if you've done my videos, because in my videos, I have talked about that Neisseria gonorrhoeae is resistant to several antibiotics. It shows both plasmid mediated as well as chromosomally mediated resistance genes. So I've talked about penicillinase producing Neisseria gonorrhoeae, tetracycline resistant Neisseria gonorrhoeae, as well as fluoroquinolone resistant Neisseria gonorrhoeae. There's a special slide in my video talking about this kind of resistance. So answer is gonorrhea. This drug resistance is seen in this STD. So syphilis, we know the drug of choice is penicillin, and Treponema pallidum remains exquisitely sensitive to penicillin even after years of use. Chancroid, it's treated with azithromycin. There's no resistance. Donovanosis is treated with either doxy or azithro. There's no resistance reported. Okay. Which of the following immunodeficiency diseases predisposes to infection by catalase positive organisms? This is a question, you know it or you don't know it. The answer to this is catalase positive organisms can cause infections in which of the following? Chronic granulomatous disease, right? You can remember it as catalase positive disease. So, catalase positive organisms cause lots of infections and granulomas in chronic granulomatous disease. What is the defect in CGD? It is a phagocyte defect. Okay, it's one of the phagocyte disorders. And here there is a defect of the NADPH oxidase enzyme. So there are 5 genes which encode the 5 components of this NADPH oxidase, and this enzyme is activated whenever there is a respiratory burst following phagocytosis. So, oxygen radicals like superoxide, hydrogen peroxide, and hypochlorous acid, these oxygen radicals are generated and they help the phagocyte to kill the organism it has taken up. Okay. Now, in a normal patient, lots of hydrogen peroxide is generated. So, even if the phagocyte has phagocytose, a catalase positive organism, this catalase can, yes, it can break down hydrogen peroxide into water and oxygen, but H2O2 is produced in so much excess in a normal organism that catalase positive organisms can be killed. However, whenever there is a defect in this, obviously the amount of H2O2 produced is very less or absent. So, in such individuals, so whatever little amount of hydrogen peroxide that is produced is broken down by the catalase positive organisms. They will immediately produce the catalase enzyme, and that will break down the hydrogen peroxide into H2O and water. So they will be able to survive in the phagocytes and cause infections associated with granuloma formation. Okay. So, how do we remember the organisms which are dangerous in chronic granulomatous disease? Just remember them as catalase positive organisms. In fact, this question was asked in 5 years back in INI-CET exam, or it was AIMS at that time, that all of the following organisms are dangerous in chronic granulomatous disease except. And what was the exception? The catalase negative organism. And can you think of the bacteria which are catalase negative? Do you remember? Streptococci, mean also enterococci, right? So that was the answer at that time. Okay. So, but sometimes here are specific organisms. So just remember this mnemonic. Cats have been places. Okay. So the B stands for Burkholderia cepacia. Which other disease do you associate with Burkholderia cepacia along with chronic granulomatous disease? Where else is it dangerous? Cystic fibrosis. Then we have nocardia. P is less important, but yes, since it is part of the mnemonic, I will definitely write it. Pasteurella. L is listeria. Now come to fungi. A is aspergillus and C is candida. And then we have back to bacteria. These are Staph aureus and Serratia marcescens. Okay, let's move on to our next question. Out of the given lab techniques, which of the following can be used for sterilization of disposable pipette tips? Okay, autoclave, hot air oven, microwaving, ethyl alcohol. So here we have been asked sterilization of disposable pipette tips. First of all, this is disposable. Generally, things which are disposable, we use them as, for a single use. But here we've been asked sterilization of disposable pipette tips. So once they've been used, if you want to sterilize them and use them again, Have you ever seen disposable pipette tips? What they are? They are different from the glass. You're not being asked about glass pipettes. You're being asked about disposable pipettes. So these are micro pipettes, which are used in antibiotic sensitivity tests by the microbroth dilution, etc., or ELISAs, etc. So this is a single channel micropipette. This is a multi-channel micropipette, right? And you can see these are the disposable pipettes. Let me enlarge this image for you. These are the disposable tips. That's the dispenser where we put all the uh, pipette tips for sterilization. So how do we sterilize them? As you can see, these are made of plastics. And what have we learned? That all plastics and rubbers are sterilized in the autoclave. They should not be sterilized in the hot air oven because the temperature is too high. These would get deformed. The stuff get deformed in a hot air oven, right? So autoclave is correct. Microwaving is never a sterilization process. Ethyl alcohol does not sterilize. So our answer to this question is option A. Okay, A only. Let's move on. Negative staining of CSF mount of an HIV patient is shown in the figure. Which of the following is true with respect to the organism shown in the figure? So here is the negative stain of the CSF. Obviously, what are we going to think of? We are seeing these rounded structures. Many of them are showing budding. So this is Cryptococcus, which is causing meningitis in this HIV positive patient. Which of the following is true? We have to find out the true statement. Option A, lung is the primary site of infection. Yes, cryptococcosis is acquired by inhalation of the yeast form, the dried yeast forms. It's true. This is correct. Associated with budding yeast cells and pseudohyphae. We know Cryptococcus is a true yeast. And what do we mean by a true yeast? That it only shows budding yeast forms. It only exists in the rounded spherical form, which divides by the formation of buds. Okay, so this is incorrect. Only reservoir is man. Man is not the reservoir. Environment is the reservoir for most fungi. For in fact, Cryptococcus neoformans, what is the reservoir? It is soil which is contaminated with pigeon droppings. And what about the other species, Cryptococcus gatti? What is the reservoir? It is again soil, but that is around eucalyptus trees. Okay. So that's the environmental reservoir for the pathogenic cryptococcal species, right? So this is also incorrect. Opportunistic infections are seen in patients with CD4 counts less than 900. That I would say is a healthy individuals. Most opportunistic infections with cryptococcus are seen in immunodeficient when the CD4 count are less than 100. 75% of cryptococcal infections are seen when the CD4 counts fall below 100, right? So again, this is incorrect. So the only correct statement here is option A. A 50-year-old patient who underwent a renal transplant recently came with complaints of watery diarrhea. Stool samples revealed oocysts of size 30 into 15 microns, shown in the image. Identify the organism. Okay, so we have an immunodeficient patient who has presented with diarrhea, and we are seeing some oval structure. Can you guess what stain this is? We are seeing red against a blue background. So this is the acid fast stain. Acid fast stain. So acid fast rounded structures which are 30 microns in size causing diarrhea, we are going to think of the coccidian parasites. And since the size is 30 microns, the answer definitely is Cystoisospora belli. Okay, that's how we differentiate what are these are the three. In fact, whatever options are mentioned are the causes of diarrhea in HIV. Cyclospora, Cystoisospora, Cryptosporidium, and Microsporia. All these first three are also called as coccidian protozoa. And Microsporidia was earlier classified under protozoa, but it is now classified as a fungus, no longer a protozoa. Okay. Right. So our answer here definitely is Cystoisospora. If we are asked, the size is not mentioned, it is just an immunodeficient patient who is presented with diarrhea and we are seeing acid fast structures, we are going to first think of Cryptosporidium because that's the most common cause of diarrhea in immunodeficient patients like HIV or transplant recipients. Okay. But here, since the size is mentioned, this is definitely Cystoisospora. So, Coccidian protozoa, these are the names. Of course, Cryptosporidium hominis also, right? So when we see the stool sample, we see this is they form acid fast oocysts. The patient passes out in the stool acid fast oocysts. Okay. And these are rounded 4 to 5 microns size in case of Cryptosporidium. In case of Cyclospora, these are double the size, 4 to 5 micron becomes double 8 to 12 microns, and cystoisospora, they become even bigger, 20 to 33 microns. And here it is oval in structure. There it was rounded, here it becomes oval. Okay. Now, an easy way to remember is when we write all of them, write them alphabet. Of course, all of them are starting with C. So let's go to the second alphabet. R comes before Y, right? So Cryptosporidium, right first. Next comes C, Y. Both of them are having common. So we come to the third, Psych, C, and here it is S. Write them in that order and keep on increasing the size of the oocyst. All of them produce acid-fast oocysts. Which of the following parasite reproduces directly from egg to larva without fertilization through parthenogenesis? Right. So here we are being asked which is the parthenogenic parasite, and in the whole of the pathogenic parasites, we have only Strongyloides, which is able to, the female worm is able to lay eggs without getting fertilized by the male worm. That is called as parthenogenesis. And another important thing is about Strongyloides is that it is ovoviviparous. The moment the female lays the eggs in the gastrointestinal tract, the rhabdidiform larva immediately hatch out. That is called as ovoviviparous. Okay. With the rest of them, none of them, the males always need to fertilize the females before they can lay eggs. Which of the following is the best test used for malaria parasite speciation? Okay, so acridine orange stained thin smear, Giemsa stained thin smear, Giemsa stained thick smear, and quantitative Buffy coat. Now, for malaria parasite speciation, definitely QBC is never used. I hope you all know this is also known as the microhematocrit tube method. I've talked about it in our videos that this cannot speciate. It can just identify the parasite. Yes, it is much slightly more sensitive than our, preparing the peripheral blood smear, more sensitive, but it cannot identify which species it is. It is more expensive. It requires a special microhematocrit tube. It requires a centrifuge and so on, right? And of course, it also requires a fluorescent microscope. So this is not helping in speciation, but yes, it does help in parasite detection, more sensitive than the smears. But what is the gold standard? We've learned in our class that gold standard for diagnosis of malaria is microscopy, prepare thick smear and thin smear. Thick smear is going to help us detect the parasite. Thick smear, look at that. That is the thick smear. This is containing at least 40 layers of blood, one on top of each other. This is the thick smear. It helps in parasite detection. Parasite detection as well as quantification of the parasite. How many parasites are present per microliter of the blood? Okay. But thin smear is used for speciation. Here we just have a single layer of blood. We can see the morphology of the parasite inside the RBCs beautifully and identify which species it is, right? So obviously, this goes again Now the fight is between these two. Both are thin smear. One is acridine orange, that is the fluorescent dye. The other is Giemsa stain. Giemsa, we know this is the commonly used. In fact, we have a modification of the Giemsa stain, which is used in our country. You remember the name of that stain? Jaswant Singh Bhattacharya, or in short, JSP stain. That's a, and a briefer version of Giemsa stain, right? So yes, we know this is very good for speciation, but here we have a fluorescent dye, and this fluorescent dye, several studies had. I don't talk about it in my class because it is not commonly used. It requires a fluorescent microscope, obviously, and we don't have fluorescent microscopes in all laboratories. Okay, yes, it is a thin smear, but it has several studies have been carried out comparing the acridine orange thin smear with Giemsa stain thin smear, and they say that this is superior to using a fluorescent dye for speciation. Easily, the morphology of the parasites are not easily identified by the fluorescent dye. So, undoubtedly, the answer is option B. Always remember, in malaria, the gold standard for diagnosis is prepare a peripheral blood smear, identify the parasite, identify the species. Even if the nucleic acid amplification tests are mentioned in the options, you will not mark them because you want to identify which parasite it is, which species it is. Okay, let's move on to our next question. Read the following two statements and answer. So, the first statement is an assertion. Late trophozoite and schizont stage in Plasmodium falciparum are not seen in blood smears. The reason for this mention here is the RBCs show cytoadherence to the endothelial cells of the internal organs. Yes, this is absolutely true in case of Plasmodium falciparum. I've mentioned it categorically in my videos. You do not see the late trophozoite and the schizont stage in the peripheral blood smear. The reason for this is because the parasitized RBCs are adhering to the endothelial cells of the capillaries in the various visceral organs. The reason for this is why? What is the reason? Anybody remembers what is the reason for this? The reason, this is the peripheral blood smear of, I just brought the picture to show you. You can just see the ring stages, which are the early trophozoite. You can see multiple rings. That's a typical feature of Plasmodium falciparum. Then you can see multiple chromatin dots. You can see acole forms, the applique forms, and you can also see the crescent-shaped gametocytes. But where is the late trophozoite stage? Where is the schizont stage? The reason is because these stages inside the RBCs are sticking to the surfaces of the capillaries, the endothelial cells of the capillaries. The reason for this is here we have a parasitized RBCs. Okay, you're not seeing the trophozoite, please forgive me for that. But what is expressed on the surfaces is these knobs. These knobs are composed of Plasmodium falciparum erythrocyte membrane protein 1. And these knobs can adhere, they can bind to their ligands which are expressed on the surfaces of endothelial cells. For example, ICAM1. In brain, ICAM1 is expressed on the surfaces of endothelial cells, and that's what this PFEMP1 is going to stick to. And this is going to lead to sequestration of RBCs in the capillaries. And hence, there is going to be compromised blood flow. More and more RBCs come and adhere. There is rosetting occurring. There is autoagglutination occurring apart from the cytoadherence. And this is responsible for the sequestration of RBCs. So our assertion was correct. The reason also was correct. Okay. So both, and this is the answer to this. The reason is the correct explanation of the assertion. Which of the following is not a clinical manifestation of Parvovirus B19? Again, Parvovirus is a very important topic for INI-CET exam. We've been asked, it does not cause which of the following? Does it cause hydrops fetalis? Yes, hydrops fetalis is of two types. It is of immune and it is non-immune hydrops fetalis. And we know that the most common cause of non-immune fetal hydrops is parvovirus B19. When a pregnant female in the first half of her pregnancy, she has a primary infection with parvovirus, there is a 33% risk of transmission to the fetus across the placenta, and it can cause fetal hydrops. Okay, so this statement, yes, is correct. Febrile illness with petechial rash. Is this correct? Well, I looked in the best textbook for infectious diseases, but in that, petechial rash was not mentioned. It can lead to maculopapular rash. It can sometimes lead to vesiculobullous lesions. It can lead to papillopurpuric gloves and socks syndrome type of rash, but it does not present with petechial rash. So this is my answer. Let's read the other options. So this is definitely not my answer. Okay. Transient aplastic crisis in children with hemolytic anemia. Well, absolutely right. It can cause this. And persistent anemia or pure red cell aplasia in immunodeficient individuals. Absolutely right. So our answer is this one, right? It does cause a rash illness, but that does not generally present as a petechial rash. So amongst the options, my best possible answer is option B. An 18-day-old baby presents with altered sensorium, neck rigidity with vesicular lesions on the anterior abdomen and forearm. The mother revealed a history of treatment for painful genital ulcers in the genital region 1 year ago, and the baby was born through vaginal delivery. Scrapings from the lesions reveal multinucleated giant cells. Which of the following is the most likely involved organism? Before we read the options, it's pretty obvious this lady had herpes simplex infection, because that's one of the causes of painful genital lesions which can transmit to the fetus during vaginal delivery. So she had an infection, and whether it is a symptomatic or an asymptomatic infection, it can be a reactivation in the pregnant female. The infection can transmit during vaginal delivery to the fetus, and this is presenting as neonatal herpes, which can present as both lesions, skin lesions, mucous membrane lesions, as well as encephalitis. That's the patient child suffering with altered sensorium with skin lesions. And of course, we have another hint to us. Multinucleated giant cells are seen with zank. So this is zank smear. We took specimen from the base of the lesions and we saw multinucleated giant cells. This is obviously herpes simplex infection. Here the option is HSV2. Okay. Neither of these can cause painful genital lesions, which can transmit to the baby. Match the following viruses with their genome. That is so easy. Whenever I start my lectures on virology, I always say that virology I consider so easy, because most of our questions in our exams regarding viruses talk about which family it belongs to, what is the property of the family. Okay, and just knowing the name of the disease would do 70 to 80% of your job for your exam. Okay, so know which virus belongs to which family, like rotavirus belongs to reovirus, JC virus belongs to polyoma virus, and Epstein-Barr virus is a herpes virus. Know the family name and its members. Then know the properties of every family. What kind of genome does it have, whether it is enveloped, non-enveloped, where does it replicate, and so on. Okay, that would do lots of your job. So before we read these options, let's just quickly go through what I've taught you in my videos, that we have 7 families of DNA viruses. All the rest are RNA viruses. So DNA viruses are happy viruses. And what are these? Herpes, Heppadena, Adeno, Parvo, Papilloma, Polyoma, and pox viruses. So these are the 7 DNA viruses. And amongst them, all of them have a double stranded DNA genome with one exception. And the exception is parvovirus. Parvovirus has a single stranded DNA genome, right? So, know the DNA viruses, rest all of them will be RNA viruses, and all RNA virus families. There are at least 16 RNA virus families, and all of them have a single stranded RNA genome with one exception, and the exception is reoviruses. Reoviridae, the important member is rota, and reoviruses have a double stranded RNA genome, right? So all DNA viruses have a double stranded DNA genome except parvo. All RNA viruses have a single stranded RNA genome except reoviruses. Now let us go back to what we have been asked. Match the following viruses with their genome. SARS-CoV-2. SARS is a coronavirus and it's an RNA virus, and all RNA viruses have a single stranded RNA genome. Rotavirus is an exception. It is a reovirus. It has a double stranded RNA genome. Then coming to human papilloma viruses, we know they have a double stranded DNA, and parvovirus, it has a single stranded DNA. Okay, so that's regarding our questions that were asked in the INI-CET May 2024. Bye-bye.